Today's training, we're going to talk about exercise for Parkinson's and the research framework that the boot camp is based on. I have Laurie King with us today, who is on our Brian Grant Foundation's Medical Advisory Board and is a researcher at OHSU who is part of this, the work that the Brian Grant Foundation's boot camp is based on. So with that, I am going to turn it over to Laurie.
The period of time they monitored, they found that 34% of the people were considered fallers, and 62% of people with Parkinson's disease fell each year. So you can see when they break this down by disease, you can see that Parkinson's was actually the highest group of people that had falls in a 12-month period, followed by syncope and other disorders, epilepsy, stroke, MS. But you can see that Parkinson's is right up there in the front. So falls is a really important thing that we need to consider, even when people are not falling, it's something down the road that they're likely going to be facing. So it's important to think about that early on. Next slide. Okay, so what we know, and I know you had a lecture the other day from Dr. Brodsky, but one of the things with Parkinson's is a dopamine depletion in the basal ganglia. So what we know about the basal ganglia is that it processes information from a lot of different areas of the cortex so that many behaviors can be affected. When we think about Parkinson's, we often just think of the motor components because that's what we see most obviously. In that first panel, you see the relationship to the sensory motor cortex. But what we also know is that there's associative circuits and connections with the limbic circuit that are going to affect other things like attention and inhibition and inflexibility, as well as things like apathy, depression, and addiction. So it's important to consider the basal ganglia as diffusely connected to the cortex. So we see a lot of different problems with Parkinson's disease. Next slide. So I'm talking to a group of trainers here, and so you all know the importance of exercise, so I probably don't need to convince you of that. But what I did want to say is, why is it especially important, maybe even more important for people with Parkinson's disease to exercise? And some of the reasons are, I've listed here. So Parkinson's is a progressive disease, so they're going to keep getting worse, and we know that's progressive, and we know that the motor decline occurs with Parkinson's. Another consideration is that the medications that people take, levodopa replacement, helps a lot of things, and deep brain stimulation, but they don't help with balance. And we've seen that in the lab. There have been several publications about that. So really, exercise is being looked at as something that, one of the only things really that at this point may help with balance over time, since we know that the medications and deep brain stimulation don't necessarily help with that. We want to use exercise to avoid falls and fractures. So people with Parkinson's are 5 times as likely to fall as their age-matched controls. And in a large meta-analysis, where they pooled many different studies, they found that 46% of people with Parkinson's fell during a 3-month period. So that's a really high number for such a short period of monitoring. And of these, 21% of the people who did fall were considered non-faller. So this was, in other words, it was their first fall. So even if you have a patient that's not a faller, there's a fairly large percentage of chance that they're going to become a faller. So it's important to consider even non-fallers as potentially benefiting from falls prevention programs. And women with Parkinson's have a lower bone mineral density, and they're 2.6 times as likely to get a hip fracture when they do fall. And then lastly, there is evidence from the animal literature that exercise may slow disease progression, and it may actually be neuroprotective of the dopaminergic neurons. Next slide. So this was a study done by Carolyn Kurtz just in 2015, and she looked at 105 people with Parkinson's, and she looked at their gait and balance, both on and off levodopa. And what she found from looking at this, you can see that she broke gait and mobility down into these different parameters on the left-hand side. So the more obvious ones we often look at are things like walking and arm swing. Those are things we can see quite easily. But then what she broke this into a turning task, and we know people with Parkinson's have trouble with turns. So she looked at turning separate from walking. And then she looked at components of walking that constitute dynamic balance. So those are things like how much time do they spend in double support during walking. And then she looked at quiet stance as a standing balance. So that's looking at postural sway just while they're standing quietly. And so if you look at all these domains of mobility, and you look at the 0 means no change, so they're tested off their medication, they take their medication, they're tested again. And if it's 0, it's no change. And along the bottom axis is the standardized response mean. And with that scale, you can consider anything between -2 and 0.2 to essentially be no change. Anything above 0.5 is considered a moderate change, and anything above 0.8 is considered a large change. So for all these gait and balance measures, none of them largely changed between their on and off states of medication. You can see some of them were in the moderate level. So some of the things like arm swing and stride velocity and stride length, those moderately changed with their medication. Some of those were pretty good, actually, like around 0.7. But most of these other measures really didn't change, and even some of them got worse with the in the balance measures. So this is just kind of a graphically looking at the fact that medications really don't help balance much, and that's important to remember when we see our patients. Next slide. So some of the more obvious, like I said in the slide on the basal ganglia, the motor deficits in Parkinson's often are the most obvious ones we see, but there's a host of non-motor symptoms that accompany Parkinson's that really may impact a person's ability to exercise and ability to benefit from exercise. So some of these are listed here, and I have the ones in pink are the ones that stand out to me as being important mediators for how they're going to do with exercise. So if they have depression or apathy or cognitive decline, those are big considerations for their exercise program. And they're autonomic if they have postural hypotension. We need to be really aware of that as we're changing positions and going from up to down. And especially when we see the more mild people who we do a lot of postural transitions with these people up and down from the floor. Next slide. And this is a continuation of the non-motor. So sleep is a big problem, and that obviously, as you can imagine, can really impact your ability to exercise. And also things like pain and weight loss and other GI problems can affect it as well. Next slide. And this was a study we did where we looked at all the comorbidities that people had in their different systems and looked at them and compared to age-matched controls published in the literature. And so this broke it down by organ system. So the top one is psychiatric illness, then eyes and ears, musculoskeletal, genitourinary, and respiratory, and lower GI were kind of the top ones. So what this is showing is the Parkinson's patients are the bar graphs, and then if you see the little dotted line, that's where their controls, the published normative values are in the literature. So you can see that they had more comorbidity problems with things like musculoskeletal problems and eyes and ears. So it's really important just to keep this in mind as you're working with people and planning an exercise program for them. Next slide. So the more common treatments for Parkinson's that you've heard about from your talk from Dr. Brodsky were the dopamine replacement and deep brain stimulation. And some of the problems that occur with these are things like the motor fluctuations, the on and off, and the dyskinesias. And then exercise is what we're going to be talking about today as hopefully a way to treat some of these conditions like balance that aren't necessarily helped by the regular treatments that we have today. Next slide. So this is a schematic to show you. Basically, wanted to just point out that balance and mobility it's a complicated phenomenon. So some people, when they think about balance, just think, can you stand on one foot? Then if you can, maybe then you think, okay, their balance is pretty good. But what we think is the systems model. So balance is comprised of all these different domains. So the first is biomechanical. You need to be strong enough to stand on one foot or to walk. But there's all these other things that aren't as easy to capture when you see your patient. So testing their limits of stability. Anticipatory is how does someone prepare for a movement? So if someone's An example would be if you're going to open the door, you don't activate your arm muscles first, you activate your trunk muscles. Otherwise, you're going to fall over when the door opens. So it's how does one prepare for a movement? Postural responses are how do you react if you're pushed off balance? So if someone bumps into you, what's your stepping response, or how do you respond? Sensory orientation is how do we use sensory information, like our vision and our vestibular system and our proprioception. How do we use that for balance? And then lastly, stability and gait. And this encompasses what's sort of obviously missing when you look at this is cognition, because we know now that balance and cognition are very, very related. And when you go to, this is a test called the BEST test, you'll see that stability and gait encompasses cognition. So how do we measure that in the clinic? So these are kind of just a schematic to think about when you're thinking about your own people you work with and when you're thinking about their balance problems. Next slide. So these are the constraints that we think about when we think about what limits people with Parkinson's. And basically, these constraints that we know about, they're fairly predictable as the disease progresses. So not everyone has every single one of them, but they're common enough that we feel confident in putting a list like this together, saying these are the things that really likely are going to occur as Parkinson's progresses. So you might as well know that in the beginning and start working on these things early on. And when you're designing your exercise program, design them around these constraints that you know are coming around the corner for people with Parkinson's. So what we have here is the constraints of rigidity, and that's a biomechanical. So those are things like muscle co-contraction, axial stiffness, and the typical flexed posture that you see. Bradykinesia is the small movements. So these are like the small steps, the small arm swing, small postural responses, and I'll talk more about that in a minute. We see freezing of gait often as the disease progresses, and we see people that have freezing of gait have very small anticipatory adjustments prior to taking a step. We see problems with sequential coordination, and this often starts with having trouble turning over in bed, but we see it also in turns, regular turns during walking, and then we see this in difficulty in changing between conditions. Sensory integration, we see a reduced kinesthesia, so people with Parkinson's often have a distorted sense of their movement. So they might think they're talking louder than they actually are, or they might think their steps are bigger actually than they are. And then lastly is cognitive problems. Next slide. So I'm going to touch on some of these, and sort of as we go through, you can think about how would you consider these constraints when you're designing an exercise program for a person with Parkinson's. So this is a picture of very typical Parkinsonian postural alignment. So very flexed. You can see all the flexor muscles shortened, like behind the knees, the hamstrings, the hip flexors, shoulder, head. And with this, we also see a rigidity, a stiffness, a decreased range of motion, and an increased fatigue. Next slide. And so we wondered in our lab how much of people's balance problems is actually just due to their stooped posture. So maybe if we fix that, they'd have better balance. So what we did was we designed a study where we had the control subjects in regular stance, and then we had them stoop down, sort of mimicking a Parkinsonian stance. And then we had patients with Parkinson's disease. And we tested them on how stable they were. And so the way we tested this was we'd have the platform move, and you can the way we can test this is we have markers on their body, so we can look at their center of mass, which is sort of the center point of their body projecting downward, and then we can look at their center of pressure from the force plates. And the bigger that margin is, the more stable they are. So we call it a stability margin. Next slide. And so this is what we saw. So we had a platform that we had them moving in different directions. So what this on the left here is showing is their stability margin. So like I said, it's the difference between their center of pressure and center of mass. So another way to think of that is how much leeway do they have before they have to actually take a step? Like if your center of mass is right at the edge of your base of support, you have to take a step. You're unstable. So it's another way of thinking sort of how much leeway do they have before they have to actually do something or they'll lose their balance. And so you can see this is all these different directions, forward, backward, left, right. And you can see the upright controls, this kind of maps out their margin. So more of a margin is better here, obviously, if you can imagine sort of standing in the middle here. Then the stooped controls did have a shortened stability margin, so it did affect their balance, but not as much as the Parkinson's patients. So the stooped posture explains a lot of their balance, but not all of it, as you can see here. And interestingly, what we found when the platform moved, the more likely direction for people with Parkinson's to lose their balance was backwards and towards the assistant who was spotting them. And so that's sort of an interesting practical point to take away when you're thinking about your own patients. When you're challenging them, be really careful about the backwards falling over, because they don't have a very good response often to stepping backwards to catch their balance. Next slide. So another biomechanical consideration is their muscle activity. So when we put EMGs on people to measure their activity of their muscles, you can see here in the pink that these are the Parkinson's patients off their meds, and then yellow is them on. And you can see so what we're looking at is the tibialis and gastroc, quadriceps and hamstring and paraspinals. So, and all they're doing is standing there. When you look at elderly controls, you can see there's very little activity, muscle activity for quiet stance in these muscles. But when you look at the Parkinson's patients, there's too much activity, especially in the flexors, and they're co-contracting. So on both sides of the joint is muscle activity. And this is just in quiet stance. So that's something to consider when you're thinking of working with them for rigidity and range of motion. They have this tonic activation of their muscles, which is not helping them. Next slide. So another biomechanical factor to consider is what we call the cone of stability. And this relates a little bit to the stability margin I was talking about. So if you look at this woman that has the cone drawn around her, and you can try this yourself, you should be able to keep your feet in place and lean in all different directions in a stable cone. And what happens with people as they age and with disease process is that cone starts to shrink. And it shrinks in reality, like people actually can't sway as far, but it also can shrink with a perceived like fear of falling. So people become afraid to push their stability margins out, and that's something we can work on with exercise. And so you can see here, like the healthy elderly can lean forward using a very appropriate ankle strategy. So just moving really just at the ankle. Someone with either aging or like with Parkinson's would do the same movement, but they'd have to use a hip strategy, which is a little bit more of an effort. And then even beyond that, they'd have to take a step. So this is something we work a lot with our Parkinson's patients on, having the correct strategy for the correct condition. Next slide. This is just showing how this is someone standing on a force plate in physical therapy, and so this is them standing in the middle, and they're just trying to lean towards the target. So you can just see, actually, you can see here how little they can go in the backwards direction, which goes back to my point about backward stability. They just didn't feel comfortable leaning back to try to get their weight to that target. And so they worked on it for a couple sessions, and you can see the same person could make a lot of progress just using this kind of visual biofeedback. So they're able to do it, they just need to practice it. And we'll talk more about this in a few minutes, but this is a task that uses visual cues. And so it's important to consider how you use cues, and we'll get to that in a minute. It's important for all regardless of whether you have Parkinson's or not, but because typically you don't want someone to become overly dependent on a cue. Like, you want to use it to achieve the task, but then you want to transfer the skill to some kind of a functional task so they're not relying on vision for their movement. And this is even more so with people with Parkinson's, and I'll talk about that in a minute. Next slide. Okay, this is a video of someone doing Tai Chi. Now, Tai Chi is an example of an exercise that really could work on widening your stability limits, so making them bigger. It's very purposeful shifting of weight. And you can see this person Tai Chi typically involves the hands too, but he wasn't able to do that. It was sort of too much to think about everything all at once. In this particular exercise, he was really working more on his weight shifts. And if we tried to add the arms in, it all fell apart. Like he couldn't do too many things. So this is an example where we had to start with one thing, and then we would slowly progress him as he was able. But Tai Chi is actually had one of the few programs that's been studied quite well for Parkinson's, and there's several publications. Fusang Li in 2012 published a nice paper in the New England Journal of Medicine where they compared Tai Chi with weight training and stretching 2 times a week for 6 months, and they found that Tai Chi improved gait and balance better than the other groups, and also had Tai Chi and strength training had less falls. So Tai Chi is actually quite well studied, and we think it's a really great exercise for people with Parkinson's for balance. Next slide. Okay, so bradykinesia is a slowness of movement, small movements, slow movements, and it's really sort of the hallmark of Parkinsonian movement. And so what we see with our patients is the most obvious thing is the small steps, the lack of arm swing, the small movements, small handwriting. Those are the obvious thing. But what we don't see, that's harder to see, but we've seen in the lab and in our studies, is this kind of bradykinesia is also present in their postural responses. And this is where it ties back in with balance. So when we talk about automatic postural responses, and that's like if you're pushed off balance, you might not need to take a step, but you might need to make an adjustment to keep your balance. If you think about if you're standing on the bus, you're continually being challenged with your postural response. And then the anticipatory, like I talked about with the opening the door example, these are also smaller in people with Parkinson's. So things like rising up on your toes or going from sit to stand, often the preparation is too small to achieve a good movement or a good step. And I'll talk about that more in a minute here. So next slide. So this is how we in the lab test compensatory stepping. So we have a person stand on a platform and they're in a harness, and when we move the platform, this is a control subject, you'll see that he just takes a step, and it's not very difficult for him. And that's his balance reaction. So you can see how nice and big and solid his step is, one recovery step. When we do the same thing with Parkinson's patients, this is what we see. So he took 2 or 3 tiny little steps, and you could see that he's not as stable. So he took more steps, smaller steps, and he's less stable. So we test this also in the lateral direction. So next slide. So if a person is pushed off balance to the side, they can do one of 2 things. They can take a side step like this, or they can do a crossover step like this one. And for this control subjects, both of those look fine. The lateral step is a little bit safer because you end up on 2 feet. It's kind of scary to end up with your feet crossed if you have a balance problem. But the thing about the crossover strategy is it's faster. So if you're in a situation where you're pushed off balance and you don't have time to take a side step, some people will do that because you don't have to shift your weight, and then you just keep going with the force. So when we look at people with Parkinson's, though, next slide. This is a person with Parkinson's doing the same stepping strategies. So the platform moves, and he steps. And you can see even he's much less stable than the control subject. And then let's look at him, this person doing a crossover, this person with Parkinson's. And you can see that's not very stable. So we did a study, next slide, where we looked at these postural responses to the side. And the reason why lateral stepping is an important thing to consider and to practice in exercise is that if people fall to the side, they're much more likely to have a hip fracture. And it's something that's sort of overlooked frequently in exercise programs. You know, if you have someone just doing always straight ahead gait, you're not practicing the skill of recovery stepping. So what we looked at in this study was posture responses laterally, and we compared control subjects with Parkinson's on and off their medication. And when you look at these graphs on the side, the first one is how quickly they stepped, so step latency. The second one is how big was their step, and then the third one was how fast was their step. So you can see that the control subjects all had a short latency, a longer step length, and a very fast step, compared to the Parkinson's patients who had a longer delay in stepping. Their steps were shorter and they were slower. And there was not a difference between the on and off, going back to my original point that the levodopa medications don't necessarily help balance. So what we found then, apart from the fact of their steps being different, then we looked at strategies. What strategies do people use? So what we found actually was the control subjects, 70% of the time they did a side step, and 30% of the time they did the crossover. And interestingly, the Parkinson's patients more or less had the same breakdown of their strategy. So when they were off their medication, 67% did a side step and almost 20% did the crossover. But what was interesting was when we looked at how many times they fell. So they're in the harness, so they don't actually fall to the ground, but the harness catches them. And so when you look at the people that did the side stepping, this 20%, 75% of their trials ended up in a fall. So the take-home message from this is people with Parkinson's really should not be doing that crossover strategy. And some of the exercises we do in our regular training classes, like the grapevine, we've just really gotten away from doing any training like that with Parkinson's. We really try to train the lateral side step over and over so that if a person then is pushed off balance, they're going to go to what they've been trained to do. So we stay away from doing like crossover stepping and things like that with Parkinson's disease now. Next slide. Okay, so this is a picture of a person just walking in the laboratory. And just you can see the very small steps. Mine's kind of jumping, so I don't know if you guys can see this, but he has several small episodes of freezing of gait. And most of you are probably familiar with this phenomenon where the person feels like their feet are sort of glued to the ground. And this person's having small episodes. He freezes when he turns. And typically these freezing of gait episodes become worse as the disease progresses. And they typically occur during transitional tasks. So maybe when you're first starting walking, going from just standing to stepping, or when you're turning. They also can occur when you're trying to do two things at once, when you're walking through narrow spaces like doorways, or going into an elevator, or step initiation, or if there's just increased demands like stress or anxiety around a situation. Sometimes time-sensitive things like an elevator door closing can trigger an episode of freezing of gait. But this is the people that when they do have a freezing of gait episode, they have very small APAs, like I talked about, in terms of generating a step. So next slide. I can show you more easily on this one. So in order to take a step, you have to prepare. So even before you take a step, you have to shift your weight to the side to unweight your foot and then take a step. And so if you look at the control subject, this is just taking a regular step. All we see is the step, but when he's standing on a force plate, we actually see his weight shift to the other leg and then take a step, and we can see how big that shift is. So when you look at someone with Parkinson's, and we have this person in a narrow base of support, watch him take a step. Whoops. And he takes a step. It's much, much smaller than the control subjects, but he does an okay job with that. Now, when we made him take a wider stance, and he's actually trying to take a step here, because we can see from the force plate, there's a big delay because he's going back and forth, but his weight shift was so small he couldn't generate a step. And so we think that, when people with Parkinson's have a very narrow base of support, which is kind of unusual because most people with balance problems assume a wider base of support because it makes you more stable. But people with Parkinson's, one of the reasons they may take this narrow stance is that it's easier to generate a step then. They don't have to shift as far with their weight. And next slide. What we found was that, now this is like the data you get from a force plate. So you can look at if you measure in centimeters how big the shift was to the offloading foot, you can see that this is a control subject, this top one. So the pink one is when they have a wide stance. So you can see how much more they have to shift. It's a lot more energy and work to shift over with a wide stance compared to a narrow stance. But the control subjects can scale that accordingly. It doesn't really affect their ability to take a step. When you look at people with Parkinson's, they don't scale up or down depending on their stance condition. And this may have to do with anticipatory planning, like I said, or it also may have to do with the inability to change according to the condition. But we see that they just do the same thing regardless of their stance width. So this is another thing, kind of take-home message, is be aware of that when you're working on different exercises with them. It's important to practice different stance widths because they'll automatically go to their comfortable width. So that's an important thing you can kind of change and adapt as you practice exercises. Next slide. And this is the same study just showing that the control subjects had a much bigger APA, we call it, anticipatory postural adjustment, when they went from narrow to wide. So they changed accordingly. People on their medication did actually scale a bit better, but still a lot less than controls. But in their off medication, they're completely unable to scale according to the condition of stance width. Next slide. Okay, so moving on to the problem of sequential coordination. So this is something that you can often visually see this if you're watching a person with Parkinson's perform a complex task. But how we define that is the inability to quickly change postural sets with changes in the initial conditions. And this kind of goes back to what I was just saying about the stance conditions, the inability to change. But also people with Parkinson's have trouble with coordinating multiple segments of their body with timing and sequencing actions for activities of daily living. Next slide. One of the reasons, this is about changing sets. So this was a study looking at what muscles were active when the conditions completely changed. So in the first condition, where it says control subject, the platform is going to move. And so in order to stay upright, this person is going to activate their paraspinals, their hamstrings, and their gastrocs. And you can see that along the back. They're not going to activate the other muscle like the abdominals or the quads or the tibialis because that would further pull them in the direction they're falling. So they very strategically only activate those muscles. Then when you have them sit on a stool and you also have the platform move, they smartly just quiet all the muscles except the paraspinals because they're not touching the floor. So that's a normal response of flexible postural strategies. What we see with Parkinson's is this bottom panel. The first problem is they're co-contracting. So the platform's moving and they're activating both their paraspinals and abs together, hamstrings, quadriceps, and gastroc tibia. So they're sort of just turning everything on in the hopes they won't fall, but it's not very strategically, it doesn't help them. And then when we change conditions, we have them sit on a chair and have the chair translate. Unlike the control subjects, they still keep their gastrocs and tibial muscles active. So they them and switch between tasks. So again, this is something we practice a lot in physical therapy. We practice, especially in the early stages, we practice switching conditions and quickly and effectively. So the next slide shows an example of a person. This is kind of a typical problem people later on with the disease. Well, even some people with early on have trouble rolling over in bed. So this person, the therapist asked him to roll over in bed. And that was his main complaint in coming to therapy, that it took him so long to turn over in bed. And he was showing him how he does it. So you can see he's just having trouble sequencing each part of that movement. It takes him 23 seconds just to turn over in bed. So the therapist worked with him and basically kind of gave him a different technique to roll. So you can see the next video. Takes him 9 seconds. So he's got like a strategy now. He's doing something different. His eyes are following his hands. And it takes him a lot less time to move over. Next slide. So one of the things to be very aware of when you're designing your exercise programs is to think about how you use cues and what types of cues you use. because what we saw in that last video is that, and this is what people sort of naturally do, and especially as the disease progresses, they find ways to, they use sensory cues to improve their function. And this could be auditory cues, visual cues. People find useful tricks to get around their problem. Like in that last video, sometimes breaking something down into parts versus a whole movement helps. There's a difference between people with Parkinson's have trouble with internally generated movements because the basal ganglia is very active in that. So sometimes an external cue, like a metronome, some kind of an external target, will trigger a movement that they are unable to generate on their own. But the problem is, well, not the problem, the good thing is our brains are very adaptable. So when you use a cue, you're actually using a different part of your brain. So if you have gait with, if you gait with a metronome, or if you do, use exercise in your class, you're actually increasing a part of the brain that wouldn't normally be active and decreasing an area that would be active. So the good news is it's like a strategy to use later on in the disease to help people be able to move better. The thing that I'd want to caution about is don't start doing this too early, because it's sort of like a use it or lose it phenomenon. If someone's able to generate their own movements via an internal trigger, work on that in therapy until they can't do it. So at some point you need to switch over. So if you're using cues, I'm not saying never use really important in training. If you're using them, like visual, so discs on the floor, that kind of thing, do it with intention. So you're using it to train a task, but then try taking them away and see if they can represent the movement without the external cue. Next slide. Okay, and then we talked about a little bit before that they have a reduced body schema or kinesthesia. So what we see is they have a poor, often a poor joint position sense, poor perception of their own posture and their own movement, and they can become visually over-dependent on vision. And this is true, the visual dependence is true in a lot of other disease states, and also with aging as well. People become overly dependent on their vision for balance. Next slide. This is just a slide to show you the senses that we use for balance are information from our vestibular, so our inner ear, information from our vision, and information from our joint position sense and our proprioception. Bob Paterka is an engineer here at OHSU, wrote a paper and has developed a model to look at how much we rely on each one of these sensory conditions for balance. What he found was if room, firm surface, you mostly rely on your somatosensory information, 70%, 20% on your vestibular, and 10% on vision. The minute you go to an unstable surface, so in our case, we have people working on foam and different surfaces. In the real world, you walk onto the beach, you walk out into your yard, you re-weight your senses. So you completely downgrade your dependence on somatosensory because it's no longer reliable. You upgrade vestibular to 60% and vision to 30%. And so a healthy nervous system does this automatically, and it does it quickly. And so, again, this is something we practice in therapy, and we try to help people not become too dependent on vision for their balance. Because if someone's dependent on vision, they're going to have trouble at night when they get up to go to the bathroom, or if they suddenly enter a room that's dark, if they're not able to switch really quickly between the senses for balance. Next slide. This is just a visual display of what we found. When we had a person with severe Parkinson's, the platform would move, and the red lines are when there was no target. So the platform moves, and then with their right foot, they take a little step to recover, tiny little step. But if you put a visual cue in there, you can see how much bigger their step can become. So we know they can do it, they just don't do it without the cue. And this held true for all the subjects we tested. That's what the right panel shows. Next slide. These are just some ways that we think about decreasing your dependence on vision. So we start often by using sunglasses, or we have these no-body glasses. They're also called dribble glasses that you can see ahead of you, but you can't see your feet. So a lot of basketball players will use this to dribble without having to look at their hand. So we try to use these to encourage more reliance on their somatosensory information and less on vision. And then we do a lot of things with eyes closed, changing the surface and visual cues, and then progressing the tasks to encompass more and more complex tasks. Next slide. This is an example of an exercise showing someone working on trunk axial rotation. So the panel on the left is a gentleman doing like a kayaking exercise. And so we'd have them practice without, and have their vision and say, no, we need a bigger, faster, until we get him doing the movement we want. Then we would go to the next panel. We'd either have him stand up or even sitting, and he could wear those no body glasses or even close his eyes. And then you'd want to have him maintain that same bigness and the same speed. So it's kind of working on progressing the sensory orientation. Like, we're so used to thinking about progressing weights or time, but there's a lot of progressions we can do in exercise that tap into the system in a more kind of complex or meaningful way, and sensory orientation is one of them. Next slide. Impaired cognition is something that has lately been receiving quite a bit of attention because we're finding that even in the early stages of Parkinson's, some of these executive function domains are already impaired. And this really intersects with mobility and movement. So some of the common deficits are executive function, automaticity of movement, cognitive flexibility, attention, and inhibition. Next slide. So this is how we look at it in the lab. Hopefully you can see this. We do the timed up and go where we have them stand and walk and turn and go back. So then that way we can look at steady state gait, and then we can look at turning, which is quite separate. So this person, without a dual task, actually very mild Parkinson's, does really well, really early stage. And so that took him 19 seconds. Now we have him do a dual task, and we typically do things like subtract by threes. We have them start at 197, and they have to say it out loud, so we record how many errors they make. And so I don't know if you can see it, but there's a definite slowing down, particularly in his turn. And it takes him 28 seconds to do that with a dual task. So like I said, this person's really mild because some people even just talking to them is a dual task. So if you have probably all seen people where you're walking alongside them and then you ask them a question and they have to stop to answer you. That's sort of the extreme case of dual task, troubles with dual tasking. So we always assess this and integrate that into our exercises as well. Next slide. We found that doing this math, so we had people subtracting by threes, we had the platform, it also increased falls. So we had control subjects, whether they had a dual task or not, they never fell on the platform. The Parkinson's subjects, both on and off, felt a lot more sort of blue as during math. So they felt a lot more on the platform when they were doing a dual task. So that's something to consider when you're planning your exercise program. It's important to practice, but it's also important to know that it introduces a danger of falling. So you have to carefully craft it, is what I'm saying. Next slide. This is some of the things we're doing right now in our current study. So we have a thing called the Agility Boot Camp where we work on a lot of the same things that you guys are going to be learning. Just exercises that challenge a lot of these constraints that I've been talking about today. So what we have is these different stations. We have people walking and practicing big, fast movements, big steps, big arm swing. We do a session where we practice whole body stretches and lunges. We set up an agility course, and we set this up with tasks that we know cause trouble, like lateral movements, turns, tight spaces in terms of freezing. So we do the agility course. We do boxing, which works on anticipatory and axial rotation, and then we do Tai Chi. So we have stations, and within those, then we've started adding these a dual task. So, for example, they'll be doing the lunges, and you can't see it that well, but it's a Stroop board, and below I have what that means. So Stroop is a thing where it requires inhibition. So if you tell them to look at the words and not the ink, work, so they have to do, and they have to inhibit the color or word, depending on what instruction you give them. That's just one example. Then we also have a station where we focus on prioritization, because when a person is doing dual tasks, they can either prioritize cognitive task. You sort of can't do two things at once, turns out, so you actually have to put attention to one or the other. So we have them doing these agility courses, and we'll say, now pay attention to the dual task, which is skipping letters of the alphabet, A, C, E. And then the next trial will say, now still do the dual task, but pay attention to your toe clearance, how fast you're going over. And we actually practice that switching between priorities. Then we practice set shifting, because as I mentioned, that's a problem in this group. So we have them doing step with your left, 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 right. So they have to just change it up. And then same thing, inhibition, we have a go, no-go task. So she says go, 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 no-go, and they have to stop what they're doing. And so we've sort of incorporated a lot of these cognitive aspects into our exercises. Next slide. Okay, this is just a summary table I put together, which is a lot of what we've talked about today. So the impairments are listed on one side, and then the focus of the exercise is listed on the other. And we've gone over most of this. So I just wanted to include that for you guys as kind of a summary slide for this. Next slide. And this is a way to think about progressing your exercises. So like I said, everyone's pretty good at weights and times and intensity, but these are things that are often forgotten. So biomechanical constraints are what we always think of. But you can also progress people along sensory motor lines, automaticity. So adding a dual task challenges whether it's automatic or not. People with Parkinson's often have to put a lot of attention into a motor task. So then the minute you add a cognitive task, it takes up their space, so to speak, and they get slower. So it kind of tests whether it's automatic or not. And then cues like feedback, visual, tactile, and that kind of thing. You can also progress that. Next slide. This I included as from a paper a few years back. These are the newer guidelines suggested for Parkinson's. So what we have, the American College of Sports Medicine recommends this for older adults over 65. So they recommend aerobic, strengthening, flexibility, and balance. And they give you durations and guidelines for your clients. So for Parkinson's, it's pretty much the same, but there's a few differences. So same frequency and duration, objective intensity, because people with Parkinson's have a hard time pushing themselves on their own. They think they're working harder or walking bigger. So having that sort of objective feedback is really helpful. Choosing a speed that's higher than their preferred speed, because again, there's kind of a mismatch between what they perceive to be doing and what they're actually doing. And then focusing on bigness of movements. For strengthening, they emphasize counteracting that flex posture, and again, having that objective feedback on intensity. Flexibility involving the axial and cervical muscles and stretching out those flexors. And balance is only recommended for older adults, those people who are at risk for falls. But for Parkinson's, every person should be doing balance exercises the minute they get a diagnosis, regardless or not if they have balance problems, because it's coming down the road if they don't at that time. So it's really important to practice early and try to delay that balance problem onset for people. And then it's 1 to 3 times per week for 30 minutes. So those are sort of the ideal guidelines. Next slide. I think that's it. So this is just our balance disorders lab here at OHSU. It's directed by Faye Horak, who's sort of done tons of this work that I presented today during her career. And then our lab also consists of engineers and postdoctoral fellows and physical therapists. So a lot of the work I presented is really the work coming from other people's labs in our lab. So thanks very much for your attention, and hopefully that gives you an overview before you go to your hands-on portion, where you're going to learn a lot more about specific exercises, but hopefully this provides sort of a theoretical framework for you guys.
Great. Thank you so much, Laurie. As Laurie mentioned, the two webinars last week with Dr. Brodsky and today with Dr. King was an opportunity for us to just give you an overview of what we're going to put into practice on November 5th. At the end of this week, I will be sending you guys out our manual, so you can also review the manual and the recorded webinars as well. And so when we walk into the training on November 5th, we're ready to go. We'll demonstrate the boot camp for you guys, and we will put this all into practice. We have just a few minutes, so I am going to unmute the lines, and if people have questions that they would like to ask Dr. King, please feel free to do so. We have a hard stop at 1 o'clock, so if you have a question, please go ahead and ask it now.
Hey, Faith, or Laurie, it's Ashley.
Hey, Ashley.
I had a quick question. You mentioned that medication didn't have any effect on balance, and then the previous doctor said that it's ideal to practice these balance exercises when they're on medication. Is there a reason for that?
Oh. Hi, Laurie.
Oh, there you go. Okay.
Sorry about that.
Okay, can you hear me now?
Yep.
Yeah, I can hear now.
Yeah, so we always tell people that there's two reasons. One is just safety. Like people are sort of at their best when they're on.
Okay.
So patients often ask us if they should exercise in the off state, but at this point we don't recommend that because really safety reasons. And the second thing has to do with motor learning. So dopamine is involved in motor learning. So if you're practicing a skill, you want to have some dopamine in your system. That's kind of probably the bigger reason. I mean, not bigger, but like the sort of scientific reason. The other one is just safety.
Okay, well, with that, I'm going to go ahead and end the webinar. If you guys have any